if they ask me anything on unscheduled care. We're fortunate enough to be joined by Martin Burnside from NHS 24, so he's going to pick up the mic, as it were, later on, and hopefully not do any mic drops. Hopefully none of us will. And we're also joined, I'm just going through my screen, Michael Oswald, our Chief Operating Officer, is here as well. Adam Osprey, our Head of Policy and Development, and Robbie Collins, who is our lead on the comms and web services. So, for those of you who don't know me, I'm Gordon Winter. I'm Policy and Development Officer. I'm part of Adam's team at CPS. So Adam's in control of the slides, so he has moved that on. So yeah, ask me anything on unscheduled care. So what's our aims tonight? We're hopeful to give you some extra confidence, I suppose, in service delivery, some reinforcement of what unscheduled care is, a little bit of chat about what it isn't, how the service is delivered, as well as unscheduled care's been with us a long time now, so obviously there's a wee bit word of mouth, and we'll bust some of those myths as well, and reinforce the correct information. And later on we'll have a Q&A. So once Martin's talked and we're finished in that sense of presentation, we will open it to answer your questions. Well, hopefully answer your questions. It depends how difficult the questions are, of course. So a little bit of housekeeping. You'll note your microphones are off, and you can submit questions via the chat. So you should see the chat there, so you can put any questions in there. But a little proviso, please don't answer each other's questions. And that's not because we think we know best. It's just because it can become a wee bit like a school WhatsApp chat. Somebody asks if you've got Charlie's jumper, and before you know it, there's 48 answers, 25 offshoots, and nobody's aware of what the question was in the first place, and Charlie's still not got his jumper. So we'll keep that as it is, and it makes it nice and clear for us to be able to see the questions. So just pop your questions in and we'll get to them. You can also put your hands up to come in as well. So just click on the raise hand icon, and we will hopefully see that as we go. If not, Robbie will alert us to some questions that are coming in. They can't wait till the end. And if we do get a barrage of questions and we don't get to them all, we will pick them up after the event and answer them and get them round everybody afterwards. Okay, so that's the housekeeping done. Adam?
Just demonstrating how the hands up goes. No, thank you very much. No, I'm joking. No, hi everybody. I was just wanting to add in as well, Gordon, that there are actually some questions that have been submitted in advance, so they will be answered in the course of the presentation as well. And if you've submitted your question, we will get to it at the panel session, because it may well be that it gets answered during the course of the presentation. So enter it at any point during the presentation, but you might just be waiting a little while till we get towards the end to pick up the answer. Thank you.
Thanks, Adam. And just to say as well, we are recording it. You'll see that at the top that Robbie started the recording, and we've got our AI on as well, so we can give minutes. I think that was what you said before, Robbie. We'll be able to do that. Is that correct? Yeah. Okay.
Yeah, smashing. That's correct. They're all on.
Yeah. Cheers, Robbie. Okay. So you can move on to the next slide, Adam. That's great. So yeah, a wee bit of the agenda. We'll do a brief presentation. I will start off, and then Adam's going to come in, and then, as I said before, Martin from NHS 24 will give his view, and that of NHS 24. We'll have some Q&A, and then we shall close. So that's the agenda for the evening. So hopefully we'll run to plan. So I mentioned before that unscheduled care has been with us a long time. Those of you as old as me will remember its introduction, which was 2005. And at that point, it was a welcome introduction. Before that, we had kind of a grey area where pharmacists were lending patients medication and hoping the prescription came, which is not ideal and not particularly legal. Or we were going down the emergency supply route, and patients were confused and a little bit disillusioned about why they were having to pay for their medication. So that wasn't a wonderful journey for patients or pharmacy staff alike. So it was, when it came along, it was almost revolutionary, I thought. But it really does work well. It works well right from the get-go, and it continues to be a successful service and one that we should all be very proud of. So unscheduled care as a definition can be described as care which cannot be reasonably foreseen or planned in advance of contact with the relevant healthcare professional, or it's unavoidably outside the core NHS working period. It follows that such a demand can occur at any time and that the provision should be 24/7. Now, obviously, pharmacy can't do the 24/7 bit, but we are a big part of that. And the unscheduled care component of the pharmacy contract does alleviate a lot of the pressures on out of hours, and it supports the continuity of care where patients are without their medication. So the purpose of the PGD is to allow patients to receive their medications or appliances or ACBS products from a pharmacist if they've lost them, if they've run out of them, they haven't ordered them, or perhaps there's been a problem with the medication, be it in formulation, whatever. We'll get into some of the specifics of that later on. But there must be a clinical need for the supply, and it must be clinically appropriate for the pharmacist to make that supply. So these are kind of the key drivers and the key, I suppose, the key components of the service that underpin it. So, and this also supports out of hours, I suppose, as well. If you can think of a Saturday, all the patients that are running out of medication out of hours, and NHS 24 hopefully won't be seeing as many of them as they would without the service, obviously, and certainly without the was being a lot less than they were in 2005. So, yeah, so it's a great service and one that we should be very proud of. So, you can move on now, Adam. Okay, so the inclusion criteria is greatly improved over time as the service has developed. There's now more inclusions than there are exclusions, and the scenarios are much greater for inclusion now than they were before, which is great. So there's very few instances really where you're excluded from making that supply where really it's warranted. So that's great, and that comes from the approved list as well. The list of exclusions is quite minimal in that sense. And the UCF and the framework there helps support that on your PMR, so that's your claiming as well. And the service materials include the A to Z lookup, which is a big improvement from when we first started and you had to go through B&F categories and trying to remember where medication was, and section 4.7.3.1, it was cumbersome in that sense. That was probably the one drawback, and that has all been fixed. And the A to Z lookup is a big improvement. So given the fact it's 2005 since we had it, there's been a lot of probably a lot of third-party information being passed on and misunderstandings about what the service is, what it isn't, what it can do and what it can't do. So hopefully we'll address some of that today. So the key points to supply, probably first and foremost, professional judgment. You've got to use your decision-making, your clinical and professional skills to decide what is appropriate and what is inappropriate to supply. You're unlikely to have two situations the same, and you may well have two situations the same, but the outcome may be different. But certainly the unscheduled care module allows you to fix a lot of these problems. So, like I said before, it's used where there's no prescription being presented to the pharmacy, and that might be that it's not been ordered. It might just have been stuck at the surgery if it's been signed at 5 o'clock. And Adam will talk around about some of the ways that you can overcome that as well with the portal. Or it may be that the patient has dropped a bottle of amoxicillin. It may be that a child can't take a certain flavour of amoxicillin, or somebody can't swallow a big capsule. And that allows you to change the formulation and allow the patient to get their medication. Where it is important is that you are completely aware that there was an intention to prescribe. So yes, the doctor, yes, it might be on repeat prescription. It might be an acute prescription, but maybe the emergency care portal has allowed you to, the emergency care summary has allowed you to see that that prescription is stuck at the surgery, and you're able to provide that in the full knowledge that the prescription was intended to come and probably will come to you on the Monday morning. One thing to note though is that the prescription or the form that is printed out by your PMR is not a prescription as such. You don't need to send that with your prescription bundle. A lot of places use that to notify the surgery of the supply. but that is not something that you need to include to your submission with your prescription bundle. That's purely an aid for you. Some pharmacies don't even print them off at all. So that's not a legal prescription in that sense. So that is more than enough from me at the moment. So I shall pass over to you, Adam, to carry on the presentation.
Great, thank you very much, Gordon. And I think just on that last point there about the thing you need to check for, or sorry, really the test was their intent to prescribe, which is a million miles away from where we started, which I think at the very outset of the service getting rolled out, the patients almost had to have an empty packet and had to exhume their granny to prove that they'd ever been prescribed a thing, which is thankfully long in the past, because that kind of defeated some logic effectively right at the start, because if you have lost your packet or you haven't ordered it, then you don't have a packet. If you've left it at home, then you don't have a packet. So as Gordon quite rightly said, there are very few circumstances under which you might not be able to make a supply. And Gordon and I were preparing for this. We were actually saying, well, do you know, I've seen myself as well off the back of a hospital discharge letter, because we all know that sometimes they end up in the hands of families and don't quite make it to surgeries in time, or the surgeries don't turn around the prescription in time. That's where that intent to prescribe comes. An IDL isn't a prescription, but it shows a clear intent as to what as sure as you can be is the latest medication that the patient should be on. So again, professional decision making comes into it, but there is no reason why you can't use that as one piece of evidence to help you with your decisions. Another piece you can use if you are lacking on your PMR, particularly if the patient isn't one of yours, is that you are able to access, any pharmacist and pharmacy technician across the country can apply to their local NHS board to get access to either the emergency care summary, which was thankfully rolled out across the entire country during COVID, or an enhanced tool called the clinical portal, which is available in some boards and as we're glad to hear rolling out in others. And it contains within it a version of the emergency care summary. And what that is effectively a download at the end of each business day. I think it's 6 o'clock it runs from GP surgeries, and gives you all of the current live repeats, as it were, and the most recently prescribed or printed off acutes. And that is where I think the typical use case there is patient comes to you, I've got a locum on Saturday, and it's almost certain that I'll have somebody come up and say, oh, the doctor was sending a prescription over to you. It's not there, and this is my go-to. It's an absolute must for practice to log in so that you're able to see what was actually done, and then you're able to make a supply off the back of that, because you can clearly see that there was that intent to supply there. Excuse me. If you don't already have access for one or two other of those, then I would say that is something that you should get started on as soon as possible. And again, that is where the Community Pharmacy NHS website comes in for your first port of call. You would go to your local health board section, and they will either have a section called Emergency Care Summary, Clinical Portal Access, or it might be the IMT Facilitator section. But one way or another, you will find the detail there and be able to start the application process. And that really can support patients who are finding themselves stuck, because the alternative really, unfortunately, if you're not able to get that information, is to lift the phone and start using local out of hours services, which is not as good a patient journey for anybody. So there are, however, a couple of exceptions as we use the service. There always are going to be. Some of them are legal barriers, and some of them are just situational. The most common of them is where you've got a controlled drug. PGD does not allow supply of controlled drugs. It's again a legislative thing. PGs are never allowed to support the supply of a controlled drug. So you then have got a couple of things to consider. You are looking at really understanding what it is that the patient's need is, whether they truly have none to see them until you could reasonably get a prescription. If you are in a position where the patient does have a dire and urgent need, then what you can do as one of your options is to go through your local professional to professional contact line to your health board to speak with the advisors there and see what options there are to have a prescription generated. of course, this means that the patient journey is going to be a bit tricky if we're looking to move the paper around about the place. There are also situations under which you might choose professionally to do something a little different and go on the trust of the prescription coming to you. But of course, that is very much down to the individual professional there. What you shouldn't do here, and is the case for many of the situations out of hours, is if you it is never really a fantastic outcome for anyone to direct patients directly back to phone NHS 24's main line, because that just kicks off a process where they will be in and swirling around that for hours and hours upon hours, and effectively blocking somebody else's route to actual care that they're looking for in the out of hours period. That is with one exception. Now, Martin, you can correct me if I've got this wrong, but the professional lines are still up and running in all boards barring Greater Glasgow and Clyde, and that at the minute really your recourse is limited to NHS 24 or considering your other options there. You have also got, if you have got patients who are not registered with a Scottish GP. Now, what we should have said earlier is that even if somebody is temporarily registered with a Scottish GP, they are included in the PGD and you're able to make a supply, assuming that everything else is in order. But if they are not, then you need to look at specifically what the situation is in front of you. So if it was somebody from the UK or the EEA area, then you will be able to utilise the emergency supply legislation. That will involve a charge, it will involve making records in the pharmacy, but that is still open to you, and you would need to make sure your knowledge and understanding of that is up to scratch. However, there will be other situations, particularly if you're in perhaps a tourist area where the patient is not from the EEA area or the UK, and there's not a reciprocal agreement for healthcare. So, for example, an American tourist, an Australian tourist, in which case what you are looking to do is check the local arrangements, maybe make yourself familiar before this happens to you, as happened to me a way back. It may well be that there's an agreement to form temporary registrations. It may well be that it needs to go to local out of hours services, but they would not fall under eligibility for the PGD. In terms of referrals, so we talk most of the time when we talk unscheduled care, when we talk UCF, we talk about making a supply, continuity of care for the patient for medicines that they're either repeats or acutes, that basically they've been due prescribed by others. But there is another element to the service that's there's a bit less focus on, but is just as important, and that is where a patient's need that's not necessarily around about supply can't be met in the pharmacy. So if you've made an assessment and it's something, let's say under Pharmacy First, where you would ordinarily in hours and where the patient's registered with a local GP, you would make that referral into that service or another appropriate service. If that need can't be met in the pharmacy and it's the out of hours period and that your normal route would be closed, then what this area of the Community Pharmacy NHS website makes clear is that you are able to use direct professional numbers to directly refer and get advice from the NHS territorial boards out of hours team. Now, the list of numbers gets sent out periodically from health boards direct to the NHS mail accounts in the pharmacies. You'll often see them plastered up on walls or in diaries, so I think familiarise yourself with those, make yourself find out where they are in the pharmacies if you don't know, because those are absolutely crucial, and they can turn one route for a patient if they get sent into NHS 24, as I said earlier, can be hours upon hours upon hours. And actually, in my experience of using this route, you either get fantastic advice and the patient doesn't need to see anyone else, or you will get an appointment made at a specific time out and out of our centre for them, which for them is a much better option. And actually for the service as well means they've got a pre-triaged patient coming to them at a known time, and that they'll take all the patient details from you there as well. They may need to call you back, so sometimes the patient needs to hang around in the pharmacy, but all in all, far better option than directing people to NHS 24. Move on next. So that's how the service operates in the different parts of it. In terms of finance and performance, we thought it was worth just covering, just to give you a bit of an idea of the scale and a wee bit of an idea of the use of the service and how your pharmacies are paid for it as well, because this is work. This is a workload that comes into the pharmacy. It's one that's been increasing significantly over time. So to date, in the financial agreement that is sort of moving on from last year, the total funding available for the service is just over 4 million, and remembering there are 1,250 plus pharmacies across the country. So that gets divided across them, and the way that the funding is structured is that there's a base payment that every pharmacy gets without having to do anything. It's automatically paid, and that is at £100 per month for all pharmacies, and that's to be ready to be able to provide that service. And you're saying there that your teams are up to date and you are available to have patients access that. Now, there is a little, I was saying automatically there is a small but with that, which is that technically, if we go back to all the service documentation, you must have at least one pharmacist associated with your pharmacy signed off on the latest version of the patient group direction, which gets sent into your health board, and that ensures that nothing goes awry with those payments. On top of that, there's also a fixed activity pool made up of the rest of the pot of money, and that is shared out much like the dispensing pool based on the total number of unscheduled care claims for supply that have been made for that particular month, and you get your slice of the pie based on how much proportionately you did in relation to the overall pot. I've doubled down here on Gordon's point earlier on, which is that your PMR systems may well print out CP4 forms for unscheduled care. The use for that is, and you'll see it in the bottom left of the piece of paper, it says send to GP. I would generally have a conversation with it before if you never have done. Certainly where I locum and where I've run pharmacies in the past, we've had an agreement with surgeries that we will send them across. We'll put them in the ducats to go with the drivers across to GP surgeries on the next available run, and that is for them to be made aware that a supply has been made, and ideally for them to enter that into their workflow and onto the patient record, so that importantly that also then gets subsequently uploaded onto emergency care summaries, so everybody that's involved in the patient's care has got a rounded view of the interventions and what has happened there. You don't, however, submit those CP4 forms for payment in your bundle. I was at the Guile on a visit today, and they just get picked out at a point in the process and sent for confidential destroying, because they make absolutely no, they're not a step, they're not necessary for payment. It is entirely electronic, the claim that goes through, both for the service payment and for the reimbursement of the cost of the medicine that you supply. So you can use it to support the process in the pharmacy, you can use it to support informing the GP, but there's no need to submit it whatsoever, and that goes the same for other CP4 services as well on UCF. Now, in terms of scale, just as of the start of this month, Public Health Scotland are now got into the habit of releasing 6 monthly data of the most recent 12 months of activity, and the way they report it is in terms of patients rather than items supplied. But you can see there in the red, over 600,000 patients in the last reported 12-month period accessed that service for supply. So that is really quite significant. And the last time we did an item count, now PHS don't report that, but from the data available to us, we are well in excess of 1 million items going on. So clearly that's multiple items for some patients, or indeed multiple uses of the service over time for patients. So extensively used, and that's why the funding has also crept up to try and support that delivery over time. What I'm going to do now is I'm going to pass over to Martin for a bit of a view from NHS24, because what we haven't covered is that a way back when in 2005, this was very much driven by NHS24, CPS and territorial boards to say, actually, there's something quite clever we can do here. And I know that other NHS bodies across the country are quite envious of this and how slick it is, because it gives great benefit to NHS24, and I'm sure Martin's going to tell us a wee bit more about how you guys see it.
Thanks, Adam. So my name is Martin Burnside, and I'm one of the regional pharmacists here at NHS24. as Adam said, we curate the PGD at NHS 24, led by our lead pharmacist, John Mackinaw, and supported by myself and other colleagues. It has seen various updates over the years. The general principle remains the same about supporting those patients who need access to their medicine, and the majority of those principles have been really well covered off by Adam and Gordon. It means patients are being supported by pharmacists who are generally the right professionals to be supporting with these medication-related issues where they have the tools to do so. And we hope that this PGD, is a useful tool for that. We are really grateful for the continued use of the PGD by community pharmacists. Mentioned there that over 600,000 patients have been supported by that PGD, which is phenomenal. As a individual health board, we at NHS 24, we handle over 2 million calls a year. So if we didn't have this PGD and that extra 600,000 patients started calling us instead, that would be a significant increase in our demand, which would put huge pressure on our services and on the follow down services as well. But really, this PGD generally supports a better patient journey. So I thought I would talk about very briefly what happens when it doesn't. The journey doesn't go as planned for the patient when they try to access medicine through that PGD. So if they, it was mentioned, try not to tell the patient to go and phone NHS 24. So if a pharmacy did that, what would the journey be? So the patient would go back and phone NHS 24. They might wait in a holding queue while they wait for their call to be answered. Their call would be answered by a call taker, so a non-clinician. They would enter a keyword, usually medication, use the algorithm to determine what the appropriate professional within NHS 24 was to support them. And then eventually it would come out usually that a pharmacist would be supporting. So one of our pharmacists at NHS 24 would likely be pulled in to support the call. At that point, the pharmacist within NHS 24 has a couple of options available to support them in supporting that patient. They could tell the patient that they could wait to see their GP in hours, depending on the scenario, depending on the urgency of the medication. They could tell the patient to return to an alternative pharmacy who may be more familiar with the application of the unscheduled care PGD and be able to support them. Not a great outcome because it sort of undermines the original pharmacy, and it does give us that risk where the patient sort of bounces back and forth in a loop between pharmacies and us. And the alternative, the third option they really have would be to send a request to the out of hours in the patient's local health board to request a prescription from a GP. In that case, the GP on the receiving end within the local health board might receive that request and think, oh, the pharmacies can do this now. Why is it coming to me when I've got all these other really sick people to deal with? And then sometimes we get feedback as a result of that. So all those scenarios, regardless, do tend to result in a delay in care. The positive is, though, that the vast majority of cases where a patient goes to a community pharmacy, they are successful in receiving care under the PGD when they're entitled to it, when it's appropriate. But there are some scenarios that we come across where that may not be the case, and quite often I suspect sometimes that is a lack of knowledge among the front of house teams within the community pharmacies, that maybe not fully aware of what the PGD can do to support the patients that are coming into the pharmacies. And I've experienced that myself, attending a pharmacy and being told that I couldn't get access to my medication because I wasn't a regular patient or I didn't have a prescription. Which brings me on to myths. So part of the goal was to bust some myths. Some common myths that we've had is the patient has to have been to that pharmacy before. So certainly that's not the case. We've heard things like the patient has to have had 3 supplies before that it can be given again. Not the case. It's purely a currently prescribed medication or that intent to supply, and that the patient must have that proof as well. So proof is required actually, but it's required in the same way that it was required for a pharmacist to supply under the emergency supply regulations before this PGD was in existence. And the guidance around that was the pharmacist had to have a chat with the patient basically and satisfy themselves that, you know, there was a legitimate need for this medication and a supply was appropriate. Other things, controlled drugs. So controlled drugs, not allowed under the PGD. However, it's the quote unquote proper controlled drugs that are not allowed. So Schedule 2s and 3s, there are Schedule 4 and 5s that are allowed under the PGD. But if you are not sure, double check the lookup list and they'll all be in there. The most recent addition of a drug that wasn't allowed and is now allowed is Oromorph, which is a Schedule 5 PGD. A Schedule 5, sorry, CD, and that has recently been changed from excluded to included in the lookup list. About the PGD as well, if you attend the pharmacy and you're thinking, oh, I've not signed the PGD for this health board or whatever yet, you can absolutely sign it and start supporting patients under that PGD before you even look for an envelope to post it away. So you can use it right away as soon as you're ready. Yeah, we are really grateful for community pharmacy for all they do to support patients. Absolutely, generally the right people to support patients, and they quite often have the medication there to hand. Whereas if it goes via out of hours, they don't keep a stock or a supply of these medications to support that patient with as well. So I think that's kind of everything I kind of wanted to cover, because I think you guys have got quite a lot in your presentation that's kind of covered everything so far. So Q&A.
Perfect. Thank you very much, Martin. So I think really the bottom line there is one of my mantras with this is start with the answer is yes. And it's quite a hard job to convince me why you wouldn't make a supply. Because actually you have to consider what are the consequences of not supplying here, and that's not just for the individual patient, it's for the rest of the system as well. Often it is the, I suppose, smoothest and happiest path that we can create for patients and our colleagues as well. And that's why the service is there, and that's why the service is remunerated. So absolutely crucial piece of primary care that we've got. So what we're going to do now is we've got Q&A arranged. We have said a wee bit earlier, if you use the chat, which I can now see that we've got one already in, thank you very much. If you use the chat to submit your questions, as we said earlier, if you wouldn't mind not answering each other's questions, and if you see that the question you're typing has already been put in, then if we just leave it at one of each, we will be able to get to those and answer them one by one. If we can't answer any tonight, we will take the question away, we'll get the answer, and we'll send it all out to all attendees. But what we've got first, before we get to that, is the questions and the answers to those questions that have been submitted in advance to the team at CPS here. So, and we get these quite often into the office. So the very first one there is one that caused a lot of discussion, and that is asking, what is it that urgent actually means in practice? And really there, it's just around about, is there no practical way that the patient could get a hold of a prescription, or you could get a hold of a prescription on behalf of the patient in reasonable enough time, and is it going to disrupt the patient's continuity of care? So that might be that actually urgent. It might be that they are about to fly off on holiday, but maybe not till tomorrow, but if they haven't already ordered a prescription, then that is perfectly reasonable to support them with the unscheduled care supply. So very much a liberal interpretation of urgent. It doesn't have to be blue light urgent, and it doesn't have to be somebody's actually immediately at risk of harm. It just means that you can reasonably, in the time available to you, get your hands on the prescription. And also, it's not just about time, it's about it's going back to that question of what's the impact of not supplying? Are you sending somebody off into a particularly poor journey, back and forth, and various phone calls and whatnot? So that's how I would encourage you to interpret that in the most liberal ways. Next question is in a similar vein. What does prescriber unavailable mean? And I think, again, if we go way back to the dark mists of time in 2005, I'm pretty sure at that point what it meant, and it was much stricter, was after 6 o'clock and the weekend. That is absolutely categorically not the case. Prescriber unavailable, once again, means where you know you're not reasonably going to be able to get a prescription without undue delay, without affecting the patient getting being able to take their medicine before the patient, for example, has to go away on holiday or not be around, or if it's going to mean a hideous patient journey or huge sort of effort from the system to get a valid prescription to you rather than utilising supply. So again, prescriber unavailable, liberal interpretation there to be able to support your patients. The next one is one that we get a lot more frequently now. So I'm an independent prescriber. Can I use my pad that I've got to supply controlled drugs if a patient has run out? So we now have just over half of the network at the last reporting actively running Pharmacy First Plus. So that is at least 650 odds pharmacist independent prescribers, but it's definitely a good deal more than that once you account for more than one pharmacist in the premises and relief pharmacists who are using the service. With this, your pad that has been supplied to you by your NHS Health Board is for the express purpose of delivering Pharmacy First Plus. That is currently the only NHS independent prescribing service that is contracted to, or that community pharmacies are contracted to deliver. So it is for the response to acute common clinical conditions, self-limiting conditions that people present to you with. It's not unscheduled care plus. So it's one of these situations where the answer is just because you can legally doesn't necessarily mean that you should. And there's a number of reasons for that, not least that that's not what you've been provided the pad for. There are also considerations around about your indemnity insurance, excuse me, and also that when you put your ink to that pad, you are taking all of the liability of the choice to supply it. And that's also the same when you make a supply against the PGD, but you're very much out on a limb and out on your own there. So can absolutely understand why you would reach it, because it's technically a legal route to supply those controlled drugs, but I would urge that you think that through. I always ask the question when people come in to work this through, whether it's in theory or after something that has happened or it's been picked up in the reporting that controlled drugs have been supplied on pharmacist IP pads, and then maybe the health boards come to have a conversation. The question I would always ask is, what would you have done before you were an IP? So I'm not an IP myself, and there's a number of times that this situation has presented itself to be, and as we talked about earlier, I have at times used the local board's professional to professional contact to arrange for a prescription to be generated, picked up, returned. It's not always practical, correct. There are other times where in extremis I've made the professional decision to make a supply under very specific circumstances and doing all the appropriate reporting into controlled drug accountable officers, GPHC, own business. That was my professional decision. We could never ask anyone else to do that. But the point I'm trying to make is, just because the pad's there and it's easy to reach for doesn't necessarily mean that you should reach for it. But of course, you are the ones with the patients directly in front of you at the time. Got the other question there around what is it we should do if patients are accessing the service frequently. So that one I think goes back to professional decision making. So we are not the police of this. We know that for various reasons, patients may have a lot going on in their personal lives. It may be that actually this is early signs of maybe something not quite right, or deteriorating with memory or mental state. It may just be poor administration. The key thing is we are supporting continuity of care for the patient. As Martin says, there is no rule around they can only have 2, they can only have 3, they can only have 4. What we really need to be thinking of as professionals is there a red flag here? Or do the consequences of making a supply outweigh the consequences of not making a supply? And that can only be made by the pharmacist on duty, and it can only be made based on the facts of the situation that is presenting itself to you directly. There are some times where actually what this might flag to you is that there's something clinical going on, and maybe it's just a bit of counselling. Again, one recently situation that I've come across is where maybe I've noticed that some asthmatic patients are being moved over to AIR and MART regimens, single inhaler for both preventer and reliever, but just psychologically they really feel worried about not having their old trusty Ventolin blue inhaler hanging around, and they're finding that the only route to securing that, because it's been taken off of the repeat, is to access a pharmacy that's done it for them before. And actually, that's not necessarily to say that the answer should be absolutely not, no way, but whatever happens, it should be accompanied with a conversation that says, listen, what's going on here? Can I help you with your regime? Can I help you with what your worries are? So it's a great way to pick up sometimes on patient concerns. Martin, I can see your hand is up, so I'll let you come in here.
Yeah, just for the background, that was there was an exclusion in the PGD previously that you couldn't have subsequent supplies under the PGD, and it was really intentionally removed to avoid those situations which left a pharmacist feeling they couldn't support a patient where the patient was in real need. And I do remember being in community pharmacy myself, and a patient had came in the door very breathless, had walked from another pharmacy who had said that they couldn't do it, they couldn't supply him his inhaler because they had had a supply under the PGD, and they hadn't had a prescription since. God forbid that patient had an asthma attack or anything on the way between that pharmacy and my pharmacy. But yeah, just to avoid those scenarios where pharmacists felt that they couldn't support that patient, and really kind of open up the access to the PGD, because it's like that other thing as well. Treat and refer. If the patient needs it, they need it. The fact that they're misusing it, or maybe not managing their medicines very well, that can be dealt with maybe later, but we'll deal with what they need right at this point in time.
Absolutely. No, thank you, Martin. That absolutely makes sense. And the time there was good for me to reflect actually back on the question around about independent prescribing, where I'm very much focused in on the pads that have been provided to IPs running Pharmacy First Plus. Now, what you do have as a route in IP there, actually, with that qualification, is the ability to do something privately if you so wish. So that is another route for you to consider, and you need to consider all angles of that, but I neglected to mention that. On the last one that's been submitted in advance, before I turn my head to the screen with the questions coming through on the chat, is a question around about how many days worth of medication should I supply the patient with? So again, this is very much an individual professional decision based on the situation that presents itself to you. The PGD allows you to supply up to what a normal regular cycle is for that patient. So in most surgeries, most of the time these days, that would be up to 2 months worth. It may be that something about the interaction makes you go, that's been ordered twice and not come back. Is there some sort of a reason that I'm not aware of? Perhaps I should give a little less, if there's some sort of clinical concern that you can intuit, and provide a little less, and it's entirely up to yourself how much you provide there. One of the things I wanted to talk about around this, though, was some of the practicalities that I'm sure many of you are familiar with. So if let's say the two scenarios here. If a patient presents and it's all straightforward, let's call it amlodipine or whatever the medication may be, on repeat, nothing dramatic, and they have not ordered that prescription at all, but have just discovered, completely run out and come into the pharmacy for a supply. in that case, personally and professionally, I would supply the whole load that would ordinarily be done, because if you supply part of it, then you are still having to ensure that the prescription is then ordered and is then reconciled, and then you've got a decision to make against, do you make the whole supply against that prescription, as well as whatever it is that you chose to give. You've got no right technically to supply anything other than is on the prescription, but then that could knock out of sync other medications that the patient has at home. So I would tend to go, unless there's some sort of clinical reason, if it's not been ordered at all, with the full amount. On the flip side of that, if the prescription has already been ordered, and this will vary locally as to what you choose to do and what you agree with the GP surgeries, then there is that question around about, okay, well, what is the likelihood of being able to intercept that prescription and not have the full amount dispensed again and then collected and whatnot. So you may choose to supply less of an amount there, but again, all depends on the patient circumstance and situation. If they're about to jet off somewhere or go off to work somewhere else, then actually that might push you into supplying the full amount. But the PGD enables you to support the patient in the best way that you see fit. So with all of that, Gordon, I see your mic has come off, and I can also see some text now in the chat box. So we will go, what I'm probably going to do actually is stop sharing so that we can see each other a little better. And Gordon, questions? What have we got coming through?
Yeah, some of them has been asked, well, kind of answered there already as well. We've got one question from Gordon: is Clinical Portal available to all pharmacists or just IPs? And Clinical Portal is available to all. It's not just for the IPs. It does vary by NHS board, and actually the platform varies significantly by board. That was one of Gordon's follow-ups. Can you only access patients resident in your own health board, or again, does this vary from health board? So cross health board, Adam?
This one is a tricky one, and of course, if I make something simple with a bit of effort, we could make it incredibly complicated. So and I'll be very intentional about the terminology here. So the emergency care summary, which is, let's just be blunt, that's the more basic product that was available first and is available across all health boards. So the emergency care summary, it's a web-based tool with a log-on for the individual that has registered to access it from the health board that they are working in. That is available for everyone in every health board, unless your health board has got a bit of bells and whistles and has started rolling out or has completely rolled out Clinical Portal, which has within it ECS, but can do other things like let you see recent bloods. It can let you see, depending on how they toggle the permissions on and off, it can let you see hospital appointments that are coming up and whatnot. And it's been really opened up to support pharmacies running Pharmacy First Plus to have the best possible quality consultations. The best in class is Tayside, who actually allow you to write into the GP workflow to update what's been prescribed, and that's for their IPs. So a bit variable with the Clinical Portal part, but with ECS, or at least the functionality of ECS, is available absolutely everywhere. In terms of the access for patients resident in your own NHS board, you'll have to check with your own NHS board specifically for Clinical Portal. And the question, really the other way to look at it is, if you move between health boards, then you must look to set up an ECS account with each health board that you work in to be able to access records for patients that come in and need your help without inadvertently triggering any what's called a fair warning system alerts to say, oh, there's somebody looking at a record that they shouldn't be, or there's somebody logging onto the system that we don't have registered in this health board. So that's the main key thing, is make sure you familiarise yourself with all the documents and make sure you sign up for ECS or indeed Clinical Portal for each of the health boards that you regularly work in. Martin.
Yeah, I can't answer the question specifically. We just wanted to add a few points to it. I think it's really helpful. The more information that community pharmacists have, the more they can do to support patients. certainly recall a few scenarios where a patient was coming in for a round white tablet and wanted a supply, and there was not much I could do without any further information. But I sometimes do worry that the more tools we have, and the more we rely on all, ECS and other things, we sometimes forget about what we can do if they weren't there, and then that makes it more tricky when, an IT malfunction happens and ECS is no longer available. So just remembering, I guess, you've got the other things, that chat with the patient is key. And there's other things you can do as well. If your patient has come down from Aberdeen and you're in Glasgow, if their pharmacies open up in Aberdeen and they want to know what strength their amlodipine is, but they can't remember, you can maybe phone their pharmacy up the road where they normally get their prescription from, and check there. So there's other ways and means as well, but the tools are really helpful.
Yeah, no, you're absolutely right. That was such a game changer, getting emergency care summary access, because that was the one where you would come unstuck quite early on in that classic Friday afternoon. The nobody knows what has been prescribed, but all we know is it's sitting behind a desk in a locked GP surgery. That you just ran up against a dead end and had to then pick up the phone to professional to professional. Whereas now, any pharmacist with access can do that. So I would really, if there's something you take away from this that you haven't already done, I would say absolutely go and arrange yourself access for the boards that you work in, because it is straightforward enough to do. There's a bit of reading to be done, but it's dead easy to do when you don't have a patient in front of you who needs your help. When that patient's in front of you and needs your help and you haven't got a login, you've put yourself on the back foot. So I would say, if you come away with an action point from tonight, it would be go and investigate, follow the link that Michael's put in earlier on, find your way to your own board, and the information about ECS or indeed clinical portal, and get that process started. Martin, again.
Yeah, so just on the back of that scenario, so it's worth, if you have ECS access, you're making your teams aware as well. If somebody's coming in requesting a prescription that's maybe not arrived yet from the surgery, especially if it's an antibiotic or something, considering that as another option for, instead of saying it's not here, actually, what if we check the ECS, and then we might be able to resolve that right there and then. So make your teams aware of that, I guess.
Yeah, and you've picked up on a key point there, Martin, whereby, yes, this is a pharmacist PGD. Yes, it's pharmacists and pharmacy technicians that can access the ECS, but it's a whole team effort, and it starts really at that interaction at the front counter. Because if the whole team isn't up to date with how flexible and how permissive the service now is, you might not even be aware that a chance to support somebody within the pharmacy in a short 2-3 minute interaction has actually you've not been able to take advantage of it, because that knowledge hasn't been spread across the team. So that's a really good and fair point there. Okay, so looking back towards our questions, Gordon, I think we got through a couple of those. Oh, there's one about IP prescribing privately for someone not resident in a UK or EA country, if it's clinically appropriate, if they've forgotten about the regular medicines. So again, very much individual professional decision. The medicines regulations make absolutely no comment on who the patient is or where they're from with regards private prescribing. In fact, it doesn't talk about private prescribing at all. It just talks about prescribing, and then overlaid on top of that is all the rules and regulations about the NHS. The NHS is indeed clear. You would need to refer to your the professional body in IRC Pharm, and also your insurer, to make sure that it's something that you want to do. And again, in that case, if you're looking at it, you really should be thinking about, right, well, I definitely don't have emergency care summary for this patient. They definitely don't have, if they've flown away from their home and don't have the medicine. I definitely don't have a record. And again, it's that conversation to take it to where you want. And Gordon, your last one, phenobarbital previously allowed via the PGD, but the PMR wouldn't allow it, and it was meant to be written by the CPS, has now been reviewed. So the only option now, NHS 24 or emergency supply route for 5 days. Martin, is that one you're able to come in on?
Yeah, so the lookup list really helpful in the scenario. and it's read in the lookup list, so it's not supplyable under the PGD phenobarbital. So in this case, we'd expect you to access direct referral pathways to support the patient via the local health board, preferably via a prescription or something from your local health board. But if you have other tools available to you, certainly have a look in and use them. Oh, I think that's Gordon wanting in, who was asking the question.
Yeah,
Gordon?
it was. Yeah, sorry, it's just strange because it hasn't happened a lot. But in February, we got a phone call from someone in NHS 24 saying some neighbouring town had run out of, and their prescription was locked in our pharmacy because it was a Saturday afternoon. Could we do it? We tried to do it down the PGD. It said no, it was yellow at that point in the list, but I see as of today, unless we got the date, it's gone red. So any reason why it's changed, Martin?
Is it? It's definitely not phenytoin.
No, phenobarbital. We had big things that we had big things saying that I think it was a big chat. We went back to Community Pharmacy Scotland, NHS. That it could be, and the PMR supplier. That you had to basically write it by the old CPUS form, which was used to us at the time. I believe it has been passed from the one we did in March because the payment schedule came out the day, so it looks as if it hasn't been rejected. But it is one that's annoying that this folk could desperately need it, and it is a life. It's actually a life-threatening condition. If they don't get it, we have to go either charge them or go back through the old NHS 24 local health board.
Yeah. No, you raise a fair point there, and I'll feed that into the discussions that we have. It could be a legal thing that we've tightened up on. I suspect that's going to be the only reason why something's changed in that front. But I will take it back. But currently, it is sitting as a no on the lookup list.
Yeah, as I say, that just went on today.
Yeah, I reckon that. Well, Gordon, sorry, on you come in.
No, it was on a different point, Adam. So feel free to carry on. Yeah.
I reckon that will be. This is one of the ones that, like we said earlier, we will go away and get the definitive answer and send it out to everybody that is in attendance. Excuse me, this evening, and make sure that is indeed how it should be listed on the AZ lookup. And if it's not, then we'll get feedback. And that's exactly the type of thing that I would encourage everyone, if you see little foibles or changes or things you weren't expecting or aren't explained, to feed them in. Certainly, probably the easiest route is in through inquiries at cps.scot, and we work closely with Martin and the team at NHS 24 and are part of the review process for the PGD. So if you see something, say something, and we'll attempt to sort it, or at least get you a decent answer back the way.
Absolutely. It's created via a manual process, typing things, so there's always a chance that something can go wrong in that process. So, helpful.
Okay, Gordon.
Yep. Just to come in, there was some of the terminology that were thrown about tonight. We're pharmacists, we love acronyms, we love confusing each other, and then making up ones that duplicate. However, CPUS has been mentioned a wee bit, and we do kind of band that about as well. So for those that aren't aware, CPUS was the original name for this service, Community Pharmacist Urgent Supply, which I quite liked as a name. I think it did what it said on the tin. Unscheduled care, yeah, I suppose it meets the overarching principle, but that's what CPUS refers to. Just on the subject of successive replies, that used to it was a very frustrating part of the old legislation, and thankfully that's gone. But somebody coming in for repeated supplies, it might not be abuse, it might be some kind of confusion, it might be cognitive impairment, they might just need help with organisation. But of course, you letting the GP surgery know on a Monday morning, perhaps, that a patient's been in, if somebody is trying to abuse the system, they will have their counter fraud checks on that side. So if somebody's trying to access things fraudulently and maybe gets past that line of defence, hopefully at that point it will be picked up, and it very much in the minority, of course. But my experience is patients are always very genuine with that, and very grateful for the service. So just make sure, like we said before, that the ECS or clinical portal is available to you, because there's nothing worse than feeling like you haven't helped a patient as much as you possibly could. And although it's been 21 years, a lot of patients don't even know that this service exists anyway, so the chances of abusing it is quite low. But they're ever so grateful when they realise that they're woken up on a Saturday morning. They think they're going to have to go the whole bank holiday weekend, perhaps without medication. They come in and you have been literally the answers to all their prayers. So they are very grateful and probably one of the most satisfying services that you could possibly have. So make sure you've got all the tools to be able to follow it right through to the end. That's really, really important. Adam.
Yes, I think I've got the answer on the phenobarbital one. So it is where very, very dry, dull and boring, but phenobarbital, although safe custody doesn't apply to it, is technically a Schedule 3. Now, in emergency supply legislation, it specifically talks about you can't do Schedule 3s apart from. So that enables you to make a old style or old school, as Gordon has put, a emergency supply with a charge to the patient, but the PGD legislation does not allow for Schedule 2 or 3s to be supplied ever and does not name exceptions. So I reckon that's how we've got to that position. We will still check, we will still write out to everybody, but I am pretty sure that that's where we're at. That's where we're at with it. It is a technicality, but that, now that I think about how the PGD legislation is written, it doesn't make specific exemptions within it. So there we go. And there's Geraldine coming in to clarify, can you make a supply phenobarbital under the emergency supply rule? Yes. Yes, you can. It's specifically named in the regulations. Okay.
There has been a question come in about supplying of expensive items such as Freestyle Libre has been used as an example, which is probably quite a complex example to give, but there's never been exclusions based on price. If it's in the list, if it's supplyable, it's supplyable. However, Freestyle Libre is more complex in the sense that some practices, some health boards are quite strict on that because there should only be so many supplies, and if Abbott supply things and it's not faulty, then why should that be on the drugs bill, etc., etc. It does become quite complex with that, and that's monitored more closely than a lot of medication in that sense. Martin, is that a point you wanted to come in on?
Yeah, it's something we see quite a lot bouncing through to us at 24. The PGD certainly doesn't disallow it, and it's there's links to the drug tariff and everything within the PGD document that's on the Community Pharmacy Scotland Unscheduled Care website. I don't know if we've linked that actually. It might. Do you want me to just put that in the chat?
Yep, we can do that.
That's where we'll find the PGD, and so I believe that's in the section of the drug tariff where it is allowed. I'm sure we've queried it before. Adam, I don't know if you've got more info.
Yeah, so it actually raises a broader point. So 2 points. One, Gordon's absolutely spot on. The price of the medicine has no bearing on whether or not it's allowed. And the second broader point is that the A to Z lookup list, as fantastic as it is a medicines A to Z lookup list. So you search it, it will give you all medicines, and it will either tell you yes, no, or maybe. There are very few maybes, thank goodness. But what's really important is a small sentence near the top which reminds users that this doesn't include appliances or foodstuffs or other things that are prescribable and are also supplyable on against the PGD, and that you'll be reimbursed for. So if you can't find what you're looking for at all on the A to Z lookup, it doesn't mean it's not allowed. It means you may have to go and look elsewhere, for example, on the drug tariff, to make sure that it's something that's prescribable, if you want to use that as a reference source along with what you've maybe got on your PMR or you've found on emergency care summary. But again, it's all vast majority of ACBS items and appliances are permitted for supply. So actually that's been a great question to remind us of that key point.
Yeah, and it's if you're looking at the full PGD, it's Schedule 18, the very last page of the PGD, where you'll find the info about the devices and appliances that are supplyable and not, and links to the drug tariff. But yeah, that's why we we have a less catchy name than we otherwise would have, and it's the PGD for urgent provision of current prescribed medicines, appliances, and ACBS products. So covers absolutely the lot. Generally, if it's supplyable by the GP on a prescription, it's supplyable under the PGD.
Absolutely. So, and that brings us round to a point. I think I can't see. Oh, there's another question that I'll maybe just comment on from Diane, but what we would say as a piece of advice to everybody, I'd say if you had one takeaway, it was go away and arrange yourself ECS or clinical portal access if you don't already have it. The other one would be that if you haven't ever, or if you haven't in a while, sat down to do some CPD, I would strongly suggest making your way to the link that both Martin and I have put in there and working your way through each of the sections of the PGD and the supporting documentation around about it to give you the background, to give you what's new, what's changed, what's really great now, as well as having the A to Z lookup list, which is great as a quick tool in practice. What that's also done is taken away from the size of the PGD documentation itself, so you're not sort of getting word and page blindness scrolling through it all. It really lets you focus on what the service is for, what the inclusion criteria are, what the exclusion criteria are. So yeah, make yourself a pot of tea and work your way through that when you're working your way through your CPD. The last one that I can see from Diane, just saying, wasn't aware you could phone professional to professional line to request a prescription for a patient for a controlled drug. It absolutely is a route I've used before. You might have slight variations locally. It might be that they will make an assessment of what you are asking for and requesting. If they are slammed with people who are extremely unwell, they may not be able to prioritise that, and then you've got another conversation to be having with the patient and how you get them what it is that they need. But yes, that is absolutely something that you can request through that route, but again, case by case basis there. I think that's the last of the submitted questions that we can see so far. Is there anything that anyone is still wondering? There are no daft questions, which is something we always say, but we truly mean it. If you're wondering it, then somebody else will be wondering it as well. We're a little ahead of the planned sort of hard close time at 9 o'clock because we want to be respectful of everybody's time this evening, particularly with it being a nice one out there, and we really appreciate your effort to come along this evening. Before we head towards a big thank you and a close, just a last opportunity either to fling in by text to chat any questions that you've got still lingering, or indeed just fling your hand up for a last Hail Mary. Going and gone. Okay, at least gone for tonight, but all of you always welcome to get in touch with the team at Community Pharmacy Scotland, either on inquiries at cps.scot or by using our main phone line number, which you'll find on our website, and you'll also find all of our individual email addresses on there as well. Oh, there's Debbie coming in. Access ECS often tricky sometimes. A representative is requesting a supply. Right, okay, and by that, Debbie, that would be, so the ECS terms and conditions are very scary is maybe the words, to be honest, and you get it because it's allowing you access technically to pretty much any patient in Scotland's sensitive information. So they are written by information governance people whose job it is to safeguard that information. But I did have to laugh a couple of years ago a bit when we had some questions around, we've provided ECS and hardly anybody's using it. And you go, okay, yeah, absolutely, let's work with you on seeing how we can improve access to that, to improve patient care. And when you start talking to people, they go, well, have you ever read all the documentation around about it? It's it almost starts off assuming that you're a heinous criminal out to do wrong. And one of the key things is there about getting explicit consent from the patient each time that you want to access it. So ECS is not something, to be fair, that you can just, if you're, I don't know, in the middle of a pharmacy day and you want to know something about one of your patients and they're not actually there and there's not actually a real pressing need to access it. You couldn't just access it there and then. You'd need the patient's you'd need their consent, and that's where actually having a representative is a bit of a tricky. But again, that's that professional judgment coming in there. The other thing that we didn't mention about ECS, and really the best advice is to go and read all the documentation, is that again, a barrier to people using it is that there's no test environment, and you also are expressly forbidden from searching for yourself or for a family member or whatever the case may be. And you can understand absolutely all the reasons behind that, but there not being a test environment as well sometimes puts people off. But what I can say to you is, from having used it, it is pretty intuitive once you're logged in. So get yourself the access, and the first time it's needed by a patient and you need to jump onto it, you will very quickly find your way around about it. It's pretty straightforward. So, as I said earlier, going, but the door is always open for questions. I certainly would like to thank Martin in particular for coming along this evening and giving us a bit of an NHS 24 review and perspective on the questions and answers that were given. Thanks as well for Michael and Gordon from the CPS team for presenting, and the biggest thank goes out to everybody who's come along with their own time after a long day at work on a nice evening. So very much appreciated. As I say, we'll record this. We will get the answer back out, the definitive answer on the phenobarbital, just to make sure that we've drawn a line under that one. But unless there is anything else, we will let you all back to your own evenings. And thank you very much.